Hi, everybody. This is Dr. Rick Lehman, and tonight we're in your corner with CORA. Today's date, July 29th, 2020, and we have truly one of the best topics that we have had so far in these podcasts, and we're going to talk about robotic total hip replacement. And we have truly an all-star cast. So I'm going to let Dr. Dan introduce himself, and we're then going to introduce Mr. Yaz, and then we're going to jump right in after that. Dr. Dan, you're on.
Hello, my name is Dr. Den with Optomotion Orthopedics here in Orlando, Florida.
Well, it's a pleasure to meet you guys as well. My name is Talha Riaz. I'm a physical therapist with CORA Physical Therapy in Orlando CORA Spine Center.
Super. So again, tonight's topic is robotic total hip replacements, and people have heard about different GU procedures, etc. Dr. Den, just to start out, tell us what is a robotic total hip, and explain the CT process and the whole process of how preoperatively and operatively this is different than a conventional total hip replacement.
Yes, a robotic total hip replacement is a total hip procedure in which the surgeon uses a robotic arm to assist with the bone preparation process and also implant placement, using real-time information and images of patient's hip. And the surgeon controls and operates the robot, and the robotic arm will help with the implant placement accuracy, which can be very difficult to achieve with traditional total hip replacement techniques with that robotic arm. And in order to do that, you need a preoperative CT, as you mentioned earlier, and that will create a three-dimensional virtual image of the patient, and it can show all the unique anatomy which can typically see with X-ray alone. And it helps to optimize the size and placement and position of the implant. And usually I'm very type A, so it's I like it right at the 40 degrees of abduction for the femoral component aversion is abduction, and 15 degrees for aversion. I like to optimize everything beforehand, and with the robot and preoperative CT scan, it will allow me to do all that. So I know the implant size, what my neck cut will look like, how much bone removal is going to be even before I operate on the patient.
That's excellent. Thank you. So the million-dollar question, which everyone's going to ask, is who does the surgery? Does a robot do the surgery? Do you do the surgery? Do you control the robotic arm? So who's operating in the operating room here?
It's like you said, it's a Star Wars age, but it's not that kind of Star Wars age yet. So no, it's the more accurate description of surgery would be a robotic assisted joint replacement, where robotic arm is used to improve the accuracy of the bone preparation and the implant placement. So the robotic arm is not autonomous. It still requires the input from the surgeon regarding how much of the bone you want to remove, and how you want to place the implant. And so the cool part is the robot provides what's called the haptic or tactile system to allow you to do surgery within the set parameter, and prevent me from get out of that kind of set boundary. So if you move the patient's body, the robotic arm will move with it as well. That's the coolest part.
Thank you. That was actually excellent. So to get back to kind of conventional surgery and conventional rehab, give us some pearls for prehab, Mr. Riaz, and give us an idea of what it takes to get ready for conventional total hip replacement, robotic total hip replacement, and what do you have to do, for our patients out there to best prepare to have a total hip replacement?
Absolutely, that's a really good question. Pre-rehab is all about getting that joint ready for surgery. And so usually at this point, the patient is dealing with some deficits in mobility, deficits in strength, absolutely some deficits in balance as well. So at that point, the therapist is working with them to kind of get them up to speed a little bit to prepare them, because we want to strengthen as best we can proceeding to the surgery itself, so that when the surgery does take place, they're able to recover a little bit quicker from that.
That's excellent. Thank you. And so getting back to the surgery itself, obviously people have been doing conventional total hip replacements. Right now, kind of the big buzz is the anterior approach. For years, people did conventional posterior approach. Is there a difference in approaches, anterior posterior, when you do robotics, or is it really just the accuracy of the cuts that makes the navigation that much better or that much more accurate?
So for me, I get trained with all three approaches. So it went from posterior during residency to more of an anterior during fellowship for joint replacement. And so usually my preference will be anterior robotic total hip replacement. And if the patient doesn't fit the criteria for the anterior minimal invasive way, then I'll do the lateral, which is my second choice. And that can be, all three approaches can be done with the robotic arm. And in terms of difference between approaches, I'm biased because I totally believe in the anterior hip replacement. For me, it's a true minimal invasive where I don't have to take down the muscle, and therefore my patient tend to perform very well after surgery. If you look at literature, long-term results tend to be very similar between what kind of approaches it is. And as far as the role of the robot, it's just like I described earlier. It's an improvement in terms of bony preparation and implant and a perfect implant placement every single time. And because of that, it will reduce I call it the human error with the implant placement, where it will reduce the risk of dislocation, and also optimize the implant placement. So perhaps long-term outcome can be better in terms of longevity for the implant. So overall, I think short-term improvement clinically and radiological outcomes can be different with the robot. Long-term, it can be similar with or without the robot.
So quick question before we move on here. So for years, people have done conventional total hips. It seems that clearly the accuracy is going to be better. You have a pre-op CT scan, you have somebody or a machine perfectly accurately making your cuts. You know that implant placement's better. You're right, in the literature, it seems like in preparing for this that results are about the same. But the question, I guess, are two things. One, how much time does the robotic component take, longer or shorter, versus, because there's setup time, et cetera, versus a total hip? And two, you mentioned something that's actually very interesting and people are going to want to hear about. Who's the perfect person for an anterior approach versus a posterior approach? So those are kind of two whacked out different questions, but you're up for it.
Okay, so the first question is the workflow. So for me, my setup for robotic case and non-robotic case is pretty much similar. I train with the table, but now I do without the table. And so for me, the actual step for the robot will be the pin placement as well as the registration. And a lot of it is practice. And when you do it long enough, you get pretty good at it. I remember my first case took me forever. It probably took me like 3 or 4 times just for the registration part. Now it just one on, and if it's a difficult case, then usually it's a second trial. But that is, for me, it's a long, painful process. But that is pretty much additional, I'll say 3-4 minutes for me nowadays. So So overall, it's not too bad for me because I don't use a table. A lot of it is depending on feel, and with I don't use X-rays either, and the robot allows me to get that perfect cup placement and implant placement that I'm looking for. And it's not for everybody, but at the same time, it fits my personality very well because I like to be in a millimeter of accuracy. That's how bad it is sometimes.
Okay, in part two, you're going to tell us who the perfect, or maybe not the perfect, but for a minimally invasive anterior approach, what are the criteria and what are you looking for in your patients versus a lateral or possibly a posterior approach?
Yes, for me, it's all about the size. If the soft tissue from the front will allow me to get down to my to the cup with exactly 10 centimeters incision, then it's a patient it's the type of patient I would anterior on. If he or she has a big panels that folds over, of course, it's gonna be a bigger risk for surgical site infection. And I would do lateral instead of anterior on that. So for me, it's all about the size. It's in terms of difficulty, in terms of like, whether the patient has severe dysplastic hip or not, that is not something, I'll do that anterior as well. And it's not something that would prevent me from going anterior.
Great, thank you very much. So Dr. Yaz, Dr. Den has just finished a total hip, patient's in recovery room. When does rehab start? Some patients come in and they say, hey, I had a total hip and they had me walking that same day, which is, wow, that's amazing. So give us kind of walk through patients in recovery, patient's gonna go back to the room, an hour and a half in recovery, go back to the room. Give us kind of the algorithm of what the rehab is from that moment on.
Absolutely. So definitely, you're thinking about the first 1 to 4 days of, coming out of surgery. Patients usually in a hospital at this point dealing with an acute care therapist, and the therapist's point of view right now is how can we best protect this joint, and also educate the patient on how to provide, getting from bed mobility, specifically going from supine positioning to maybe a seated position, as well as on working on how to actually stand up with the use of an assisted device, usually a walker at this point. Definitely in terms of exercises, not much is being done to mobilize the joint just yet. It's still pretty fresh, but we do want the patient to start incorporating some ankle pumps and while in bed, also some set exercises to kind of stimulate the muscles, specifically glute sets, hamstring sets, and quad sets while they're in the bed still. From there on, you're going from week 1 to week 3. Usually at this point, the patient's being prepared for discharge, going to home as well. And so they're usually meeting a home health therapist, or maybe they're at a skilled nursing facility where now they're working on increasing the strength of that limb as well, and also furthering that range of motion. So now from,
Well, keep going. So now we're either at PT or we're home health, etc. Keep going. You're doing great. So what happens after that?
Absolutely. So in this case, now the goal is to get the patient to become more compliant with their HEP. Usually from week 1 to week 3, we're thinking the patient's going to be performing at least 2 or 3 times a day, specifically their range of motion exercises. We're talking ankle pumps, heel slides, hip abduction or adduction with assistance, so maybe like a towel underneath their heel, and also just generally working on being able to work on slight strengthening exercises. So maybe short arc quads in the bed, long arc quads sitting at the side of bed, and also continuing those set exercises. And also at this point, gait training is a big deal. We want to make sure that the patient is working from walking with a walker and transitioning down into maybe a cane, and also improving their gait mechanics. So whether it's their step length and also their ability to weight bear on both sides, we want to make sure that patient is able to ambulate a little bit better before transitioning into outpatient therapy from there on out. Usually week 3 to 6 is where they're coming to me in outpatient. So here, my focus is to further strengthen their lower extremity as well as their trunk, considering the hip is attached with their lower spine and the lumbar spine. And we want to make sure now at this point from week 3 to 6 that we're working on weaning off their assistive device altogether. We're furthering their balance and proprioceptive activities and incorporating functional movement patterns. So specifically like your sit to stand, and also furthering their squat a little bit, and improving their ability to do the lift and carry, walk with maybe a little bit less assistance, and also incorporating steps. You're talking maybe starting with the 4-inch step, maybe your curb, but also furthering loading that joint from there on out. From week 6 to 12, the therapy takes at a different step, and now we're furthering that strengthening with a little bit less of a hesitation. We're making sure that patient's able to incorporate increased repetitions, increased sets of exercises. They're further improving their balance through more challenging exercises and proprioceptive activities, and actually incorporating further loading activities such as like a front lunge or a deeper squat when they're really comfortable with it. From there on out, week 12 on, which is 3+ months, we're making sure that whether it's in a higher level adult, returning back to their recreational activities such as golfing, going for those longer walks, or if it's an athlete, that they're returning back to those higher level challenging activities for sports.
Listen, you guys were both great, and seriously, it's a great topic, and obviously this is where arthroplasties are going.